Good morning, everybody. I'll be presenting on behalf of Medicine 4. I'm looking at a 21-year-old nursing student who's, from CMC who presented with complaints of cough for 1 month with scanty mucoid whitish expectoration with no positional or diurnal variation. Her cough over this 1 month was episodic, where in 1 month prior, she had the first bout of cough, which lasted for 2 weeks, for which she had not sought treatment. It had spontaneously resolved. And again, she had presented to us with the second bout of cough and with this fever for 1 week, which was high grade and chills and rigor. And this time, she also had a 1 week history of nodular lesions, which were noted over in her bilateral lower limbs with mild pain on palpation. She had no history of breathing difficulty, no history of hemoptysis or chest pain. There was a history of loss of weight of 2 kilos, but there was no loss of appetite over this past 1 month. On examination, hemodynamically, she was stable. She was not tachypneic, and she was maintaining saturation on room air. And on clinical general examination, there was no pallor, lymph nodes, or pedal edema. She was noted to have tender erythematous nodular skin lesions, which were present in her bilateral lower limbs. And her respiratory system examination showed bilateral vesicular breath sounds were present, and other systemic examination was also normal. So, though she had presented with the history of 1 week history of cough and fever with erythematous nodules, in view of the background history of the loss of weight and also this history of cough which was present over 1 month prior, we had considered looking at differentials for fever with cough and fever with erythema nodosum, out of which infectious etiologies we had considered bacterial such as streptococcal mycoplasma, Mycobacterium tuberculosis, viral such as EBV and CMV, and non-infectious causes, immune disorders like sarcoidosis, SLE, vasculitis, and rarely malignancies such as lymphoma. Her baseline investigations, her counts are slightly elevated, the neutrophil counts of 77, and there was no renal or hepatic dysfunction. Her calcium and phosphorus levels were normal. There was no electrolyte imbalance. And this was her chest X-ray, which had shown a small pacification, which was noted in the perihilar region of the left lung. And out of the investigations we had sent, so initially we had treated her with antibiotics in view of the 1 week history of fever and cough. But in view of this erythema nodosum, we had looked at associations, and TB was notoriously known to be very commonly associated with erythema nodosum. So despite the fact that she had only a 1 week history, with the background history of a cough which was untreated 1 month prior, we had sent for sputum expert in which MTB was detected. So coming to erythema nodosum, it is a type 4 hypersensitivity response which presents as painful, symmetric erythematous nodules. It is classically known to be involved in the pretibial region. All the extensor surfaces of the forearm, the thighs, and the trunk may also be affected. It does not ulcerate, and they tend to heal completely. Sometimes they do heal with hyperpigmentation, and they usually heal within 1 to 6 weeks from the time of presentation. And the diagnosis is often clinical. And most common incidents of erythema nodosum are idiopathic, around 55% of the cases. The common associated conditions with erythema nodosum, other than the idiopathic etiology, infections like streptococcal pharyngitis, which is again occupies a fair amount of 28 to 48% of causation, and Yersinia, Mycoplasma, and Histoplasma coccidiomycosis in the rare events, and Mycobacteria. Sarcoid, which is a non-inflammatory, which is an inflammatory cause of around 11 to 25% of times. With other rarely, drugs, pregnancy are the other common conditions. Very rarely, infections of HSV, Epstein-Barr, and Hep B and Hep C can also be involved, and other lymphomas and other malignancies are also known to be associated with erythema nodosum rarely. I had specifically looked at when so there are multiple case reports which is saying that association between tuberculosis and erythema nodosum. So, which is why in the olden times, erythema nodosum was previously known as a tuberculous skin disease because of the common association between the two. 20% of those with erythema nodosum have been noted to have underlying tuberculosis, though it may be more than 20% in our country, because this data was taken from the Curious, which is from abroad data. As considering our higher incidence of TB, we might have a much more increased prevalence. And it is involved in, it can be a manifestation in both pulmonary and in extrapulmonary tuberculosis. This was a journal which was published in the Journal of Dermatological Treatment in 2004, which is a study done in PGI Chandika where they had looked at erythema nodosum and initiating someone on ATT. They had assessed the response to ATT in patients with erythema nodosum. So they had looked at strongly positive Mantoux reaction with no other underlying identifiable cause. And they also not have concomitant idiopathic erythema nodosum who had come to the dermatology OPD department. Over a course of 13 years, they had done this retrospective study. So their study had looked at 52 individuals who had idiopathic EN with a strongly positive Mantoux test and had excluded 5 because of loss to follow-up. So finally, they had looked at, so out of the 52, the 47 who had looked at ATT, they had followed up. And they noted that out of the 47, 45 individuals, there were no new lesions which were noted even after 6 to 8 weeks. And in 2, the number had decreased and were less symptomatic. So what I want to summarize my presentation is that erythema nodosum is a clinical diagnosis which has a broad differentials. But one of the main things which led us to detecting the MTB in this patient at least was the erythema nodosum because she had presented with an acute presentation. And since we had screened her for an MTB in the background of erythema nodosum, her expert was detected much earlier. And so hence all patients should be screened for both pulmonary and extrapulmonary tuberculosis in the background of erythema nodosum. And this is a thought to consider if a strongly positive tuberculin reaction is present and ATT can be considered.
That picture you posted, is it the patient's photo?
No, sir. So this is taken from the internet, but the thing is, she had a similar presentation. We had showed it and we had asked her similar. By the time she had presented to us, her lesions had already started resolving, and it was more of hyperpigmentation. But we had asked her whether it initially started in the same way.
That would have been nice if you had.
By the time she had presented, it was not.
Did you examine her?
Yes, sir. So I had seen her towards the end of her course. So she did have palpable subcutaneous nodular lesions are present, but by then the skin changes from erythematous, they had become more of hyperpigmentation. She was in her resolving phase of erythema nodosum.
So the question is, suppose you are sitting in a peripheral setup where patient comes with these constitutional symptoms with bilateral minimal pedal edema, and you see these kind of subcutaneous nodules going on for a month. Okay, so how do you approach? You don't have much facilities for investigations. Maybe you have an ultrasound, chest X-ray, maybe some ESR, CRP, and few investigations only have. So will you start empirical ATT?
Empirical ATT may not be. Maybe you can try for if it is a low resource setting, Mantoux or sputum AFBs alone to be sent. And minimal work of the chest X-ray because she, in this case also, she did have a hilar opacification and minimal workup. And if it's a resource limited setting, then inflammatory markers may not have also been very feasible.
So you're saying that Mantoux is important here. Mantoux is positive.
Limited setting might be.
If it's positive, you will start empirical ATT.
It is a thought to consider because we are in a much more state where we can definitely further evaluate for TB. But if it was a resource limited setting, and that study was done in 2004.
If it is negative, you will consider other differential diagnosis.
Other differential diagnosis.
You will not study ATT. So we had one case in Chittoor when I was posted after my MD 6 months. So I had a similar case what you presented. One lady, these constitutional symptoms we had, lethargy, tiredness, and she had similar subcutaneous nodules. So we did Mantoux that was highly positive, and we tried to. She didn't have any other symptoms. We couldn't sense sputum. X-ray was negative. So ultrasound was also didn't show anything. So we started ATT, and she improved. She did improve. So exactly similar case. Yes, sir.
I think the three most common diseases are TB, coronary vascular diseases, and sarcoidosis.
Yes, sir.
In resource limited setting, I guess you do a chest X-ray and ultrasound.
Yes, sir.
The CRP and higher the Mantoux is strongly positive, the reason we start.
Yes. Any other comments, doubts from audience? So if you do biopsy of this erythema nodosum,
Reticulitis.
will you see mycobacterium,
Sir,
bacilli?
no. It's a delayed hypersensitivity.
So this is actually not a skin manifestation
Skin
of TB. It's just a sign that there is internal tuberculosis. Okay, yeah. We'll move on to the next one. It's not doing. Sure.